Let's begin here. If you're interested in helping people acquire skills at cardiac auscultation, in the 90s this was something that Sal Mangione was interested in, he published a series of reports about this very basic clinical skill and how effective learners were at various levels of training at performing this fundamental skill. The center one was published in JAMA 1997 along with Linda Zeman, Cardiac Auscultatory Skills of Internal Medicine and Family Practice Trainees. I'll violate every rule of giving a good presentation by reading from the abstract of this report. Sal and Linda report their objectives were to compare the cardiac auscultatory proficiency of medical students and physicians in training. They did a multi-center cross-sectional assessment of students and house staff. A total of 8 internal medicine and 23 family practice programs were studied in the Mid-Atlantic area. They enrolled 453 physicians in training and 88 medical students. All of the participants listened to 12 cardiac events, excuse me, directly recorded from patients, and then identified what they heard. Here's what they found. On average, internal medicine and family practice residents recognized 20% of all cardiac events. 20%. The number of correct identifications improved little with year of training and was not significantly higher than the number identified by medical students. 20% was their ceiling. So if you're concerned about auscultatory skill as an outcome of medical education, this is not necessarily very good news. But what's next? Here's a report published out of the University of Miami, 2002, again with cardiac auscultation as the skill set that these investigators were interested in. It's titled The Effectiveness of a Review Course for Internal Medicine Residents Using Simulation Technology and Deliberate Practice. Here's the data from the study. There are 3 groups. The middle group there are a group of internal medicine second and third year residents at the University of Miami. These are young people who had been on the ward seeing patients for years, doing what residents do. So we compared their performance at pre-test and post-test with 2 groups of 4th year medical students who were completing a cardiology rotation at 5 institutions. Let's see if I can remember. Miami, Northwestern, Duke, Arizona, and Emory. Okay? So they were all measured in terms of their cardiac auscultatory skill at baseline. 2 groups received an intervention. 1 group did not. They just saw patients over a 4-week period. What's of interest? Look at the pretest scores for all 3 groups. The middle group, the residents had been seeing patients for years. The medical students were early in their 4th year of training. No difference whatsoever in terms of this fundamental skill. 2 of the groups improved with slightly different teaching interventions. The group on the bottom, which was composed of 4th year students at Arizona and Northwestern, saw patients for 4 weeks and were retested on a post-test. I think the pre-test results are stunning because it shows once again that clinical education alone doesn't necessarily produce measurable differences in a basic skill like auscultation. Well, let's move on. What about surgical experience? Richard Bell, Dick Bell, good friend, was chairman of surgery at Northwestern for many years, retired from that post and became president of the American Board of Surgery in Philadelphia, recently retired from that post as well. And he and his colleagues were interested in, look at the title, the operative experience of residents in U.S. general surgery programs. The subtitle is A Gap Between Expectation and Experience. This was published in the Annals of Surgery. Let me read from this abstract as well. The objective of this study was to identify a group of operations which general surgery residency program directors believed residents should be competent to perform by the end of 5 years of training, and then ascertain actual resident experience with these procedures during their training. So it wasn't a measure of acquired skill, it was just a matter of exposure during the 5 years of surgical education. Here's what they found. 121 of the 300 operations were considered A-level procedure by a majority of program directors. An A-level procedure is something that should be, these program directors at the time thought was essential for every resident to be experienced with. Now, they go on. Graduating 2005 U.S. residents, there were over 1,022, performed only 18 of the 121 A procedures, an average of more than 10 times during residency. 83 of 121 procedures were performed on an average of less than 5 times, and 31 procedures less than once. 5 years of general surgery training. For 63 of the 121 procedures, the mode, that is the most commonly reported experience, was 0. 0. In addition, they say there was significant variation between residents and operative experience for specific procedures. So this is Osler's natural method of teaching at work. The curriculum is patients seen, and we see the results are very, very uneven. This was reported in the Annals of Surgery just a few years ago. A good friend of mine has been the residency program director for internal medicine at Northwestern for many years. And Northwestern, just like Loyola, when they select residents for the internal medicine residency program, they're very, very selective. But Diane Wayne, who until recently was a program director, discovered that despite the fact that the residents who came to her program from medical schools, they're very prestigious. The new residents, almost without exception, had very, very high board scores. When they showed up for their first day of residency training, they couldn't do anything clinically. They didn't have clinical skills. So as a consequence, Diane and her colleagues, including Elaine Cohn, who's the first author on this paper, put together a boot camp to prepare new residents at that institution to care for patients as early as possible. Sounds like a trustable professional activities. So the first boot camp experience was published recently. It expected all the new residents to demonstrate mastery of basic things like cardiac auscultation, performance procedures. They chose paracentesis and LP, management of critically ill patients, that is patients in the ICU, how to manage ventilator patients, and communication with patients. How do you engage a family in a code status discussion? If your father's heart stops beating, what do you want us to do? Do you want us to be aggressive? Do you want us to pull back? It's a very difficult conversation. But Diane and her team demonstrated that they could educate people to mastery standards to do that. This is a consequence of poor clinical training from the new residents that they were receiving. They also discovered there's no relationship whatsoever between clinical skill examination scores and age, gender, and oh, by the way, USMLE scores at all. Finally, take a look at this. This is some work that was reported recently by my friend and colleague Jeff Barsick, who's a hospitalist at Northwestern. This is published in the journal Neurology, where he put together a training program for internal medicine residents to master lumbar puncture skills. And Jeff measured their skills on a very detailed checklist that I'll share with you in a minute at pretest. What you see on the left are pretest data, and as you would expect, from these very inexperienced residents, they're all over the map. They're inexperienced. They're far below the minimum passing standard that, by the way, was established by a panel of experts. In a uniform curriculum in the simulation laboratory, 4 hours of training, Jeff was able to, 4 hours minimum training, Jeff was able to get all of these 58 learners, or they got themselves through much deliberate practice above the passing standard. 2 or 3 people needed an extra 30 or 40 minutes in order to get above the standard. On the right, you see a comparison group. Members of the comparison group are second, third, and fourth year neurology residents taken from 3 other academic medical centers here in metropolitan Chicago. These are residents in neurology who have been performing LPs for years on hundreds of patients, and they consented to be tested in the simulation laboratory as a comparison group. The figure tells the story. Despite the fact that they had years of clinical experience, done many, many LPs, when measured objectively, only 2 of these fine young people met the passing standard. So you might say, well, how is a passing standard, or how is performance evaluated? Here's the checklist. 21 items, no surprises. Everything you might expect of someone who is proficient, who has mastered the skill of performing this very, very common clinical procedure. The item that's highlighted on the bottom, I hope you can read it, asks at the conclusion of the procedure, please list the routine tests to be ordered once the CSF is drawn. Now, in the comparison group, if you read the fine print, less than 50%, 41% of the traditionally trained neurology residents knew what to do with the CSF once it was drawn. 41%. Despite the fact that they've been doing these for years. They didn't have a clue about what to do with the fluid. Something's wrong with that. These are bright people, they want to do well, they're folks just like us, but they hadn't been trained to mastery standards. So what are some of the answers? And I could go on with examples. I believe that simulation-based mastery learning with deliberate practice works. It's demonstrated time after time. We need to help people acquire these skills and demonstrate their proficiency first in controlled laboratory settings with rigorous measurement and feedback. We can't provide feedback unless we have data. We use data as a tool and not as a weapon. We try to measure translational downstream results, which are not a part of this talk. That's another talk. And simulation-based laboratory education and experience is not a substitute for, but it complements the fundamental kinds of clinical work that we all realize is so valuable. It's not a substitute, but it complements. Here's some more data. Take a look at the title. Does simulation-based medical education with deliberate practice yield better results than traditional clinical education? This is a meta-analysis. A number of years ago, the Clinical Translational Science Awards were first announced by NIH. And one of the goals of the CTSA Awards is to try to do research on the comparative effectiveness of various medical interventions. A few years into that set, the journal Academic Medicine decided to publish a special issue on comparative effectiveness research. The editor of that special issue was psychiatrist Harold Pincus at Columbia PNS, good friend of mine. And they issued a call for papers. And I scratched my head and I called Harold and said, look, would your special issue of the journal be interested in a report that compares in a head-to-head way simulation-based education with deliberate practice versus traditional education in a head-to-head comparison in a rigorous way? And he thought for a moment, he said, well, it's kind of off base. It's not what I anticipated, but sure, go ahead. So we sent on a proposal. Lo and behold, it was accepted, and we did the work. We did a very systematic review of the extant literature in those days, looking for these head-to-head comparisons. We found 14 studies that met our inclusion criteria. And you see the mostly procedural education in medicine, involving 633 learners in 14 studies, in a variety of studies, randomized trials all the way down to pre-post baseline studies. Here's what we found. Take a look. Head-to-head comparisons. In these 14 studies, without exception, simulation-based education toward the goal of skill acquisition with deliberate practice in the laboratory won hands down in every case. In no instance the error bars touch the null value. Is there a statistician in the room? Come on, fess up. No one? On the bottom, you see in the diamond the overall effect size. It's reported here as a correlation coefficient, but that translates to Cohen's d of about 2, which is huge. I've never seen one reported in literature. Without exception, rigorous, systematic, simulation-based education in the laboratory wins hands down if your goal is skill acquisition. I find these data convincing. And there's more data that have been reported in this realm since then. Well, here are some statements from the Scottish doctor group. Actually, you see in the upper left-hand corner from actually reported by the University of Edinburgh in the Tomorrow's Doctor report published in 2009. And I quote, medical schools have appropriate methods for setting standards and assessments to decide whether students have achieved outcomes for graduates. There must be no compensatory mechanism, that is, doing well on one acquisition of one skill set will compensate for a poor performance elsewhere. They say that doesn't work. You got to be great in everything. Would allow students to graduate without having demonstrated competence in all the outcomes. Then they go on. Most integrated assessment systems have some degree of compensation as an integral feature. These UK colleagues are arguing against that model. Ensuring that each of the outcomes has been passed by every student will require investment in time and resources. You get the picture. But if mastery is our goal, this is what's required. Finally, just more detail from the same report. So they're saying that if we do our job as medical educators, we will be certain that our graduates at whatever level, the undergraduate level, the postgraduate level, have achieved the milestones that we think are important, and we measure our results with rigor so that we can provide feedback to help people improve, to become better doctors, not just good doctors, but awesome doctors, and to be prepared to serve our patients safely and effectively. So what are some of the barriers? And this is my own pontificating. First, inertia. My late colleague George Miller in the 1970s took me aside once. He was very avuncular. He said, Bill, he said, the most powerful force in medical education today is inertia. That was 1974. And much of what we do is based on the Oslerian model of what he called the natural method of teaching. Very passive. And we all know that in many ways competence is ascribed socially rather than as a consequence of rigorous measurements and so forth. So we have to overcome this inertia. Second, we have to insist on rigorous, reliable measurements. It's good for our learners, it's good for our programs. It helps people get better. And once people know that they have mastered a skill, they really feel great about themselves because they know they're better doctors. We've seen this time and time again in laboratory-based studies where people work very hard. We measure their results with rigor. They walk out of the room very tired, but with confidence and knowledge that they've really improved in what they can do. We have to get over the burden, the barrier of evaluation apprehension. We all see this every day. What could be worse for a physician, either in practice or in training, to be exposed as being less than absolutely perfect? It's anathema. We've got to get beyond this. I have a good friend at my church. We were having coffee after services a few weeks ago. He's a pilot. He flies for one of the major airlines. We got to talking. He said, you know, every year I have to go to Orlando. I get checked out for 2 days in the simulator, and if I don't pass, I don't fly. I said, oh, really? Aren't you nervous about it? He said, not really. He said, it's expected. Everybody in my profession must do this. It's a part of our life. It's not true of medicine. So we've got to get beyond this idea that we're all perfect and be willing to expose ourselves to measurements toward the goal of improving our skill sets. Fourth, we need to work as teams or understand this better. Nobody works alone anymore. It just doesn't happen. We have teams in the hospital, we have teams in the clinic and elsewhere. We need to do a better job of formulating and measuring the results of teamwork. Our speakers on May 9th at the Leischner Institute Medical Education Day will address this directly. We need to be aware of what's called implementation science. Just because an intervention works in one setting, across town, across the country, doesn't mean it'll work here or in another location. Okay? Educational interventions, when implemented, are not the same everywhere. And we have to appreciate that. And just because it works in somebody's lab in another place doesn't mean we can adopt it whole cloth and make it work here. It takes a lot of work to make it fit the local circumstances, local culture. Money is usually not the issue. If we're passionate about helping people become really great docs or healthcare providers, we'll figure out a way to make it happen. It doesn't cost all that much, either in time or money. What really matters is one's passion. And finally, we have to figure out better ways to measure the very, very complex medical problems and outcomes that physicians deal with every day. How do we measure not only one or a team's skillfulness in managing that very complex diabetic patient with heart disease and many other issues? We really can't shape up our educational endeavors to help people be really expert at these very complex problems until we can measure them with some degree of rigor. And that's a real challenge that we face in medical education today. So in closing, I think we've got to get our head out of the sand. We've got to think of new ways, better ways, adopting existing technologies so that the 21st century physicians we're educating today are better prepared using 21st century technologies.